Good morning. I'm Dr. Swami Iyer with IACA. I'm here with Dr. Pallawi Torka. Welcome, Pallawi.
Thank you.
Pallawi is a third-year fellow at Roswell Park Cancer Institute, and she is presenting a couple of abstracts here at the American Society of Hematology meeting in Orlando 2015, December. So, Pallawi, welcome again.
Thank you again.
So, tell us a little bit more about your posters.
So I have two posters here, and both focus on on harnessing the immune system in the treatment of B-cell lymphoma, but the focus is different for both posters. My first poster is basically combining pegfilgrastim, which is Neulasta, with rituximab for the treatment of indolent B-cell lymphomas. And the second study is about, we looked a prospective study about correlating immune cell subsets, that is immunological recovery, with outcomes in patients after autologous stem cell transplant in B-cell lymphomas.
So tell me about the first study. It's very interesting because it's something that I used to do with your mentor, Dr. Francisco Hernandez.
So this concept is not really new, and what the rationale behind the concept is that we all know that rituximab is used in treatment of lymphomas and B-cell lymphomas, and as a single agent in indolent lymphomas and in patients who can't really tolerate aggressive therapy. But in patients who have already seen rituximab or chemotherapy, when we give them rituximab again, then even though the overall response rate is about in the range of 45 to 60%, the complete response rate is less than 10%. And so there has always been an interest to try and potentiate the activity of rituximab the second time round, to try and make it more effective and achieve more deep responses so that we can have maybe a longer progression-free survival and overall survival. So that was the rationale. So how we went about it was that it's a phase 2 study, so there's only one arm. There have been similar studies in the past, and people have used GCSF and GM-CSF, but our rationale for using pegfilgrastim, which is the long-acting version, is that patient convenience. Patients have to just get one injection in comparison to GM or G, where there are different regimens. Some people use it for 8 days, some people use it on day 1, 3, and 5. So that was our rationale of doing this study. So we could recruit 20 patients on this phase 2 study. 14 out of 20, that is the majority, were follicular. There were 4 patients with CLL and 2 patients with marginal zone lymphoma. We used the Swiss regimen, so there was an induction phase and a maintenance phase of rituximab. The induction phase is usually once every week Rituxan, but what we did was we had to give it every 2 weeks because Neulasta, pegfilgrastim, is given every 10 days to 2 weeks. So 4 doses every 2 weeks, followed by 4 doses every 2 months as the maintenance phase. And the primary objective was, of course, looking at the safety of the combination, and secondary objectives were efficacy outcomes, which are responses, OS, and PFS. So our data was pretty encouraging. Of course, rituximab itself acts much better in follicular lymphoma because of the higher CD20 epitope density on the cancer cells. So in our cohort, the overall response was around 60% for the whole cohort, with about 35% complete response rate, which is quite improved compared to the historic controls. But the more impressive results were in follicular lymphoma, where the overall response rate was 70% and the complete response rate was actually 50%. The progression-free survival was 17.9 months, so 18 months.
And what's the median follow-up for the 17?
The median follow-up was about 2 years.
2 years.
So, and then we also did the thing that we are most proud about is that we could do some biologic correlates. So we assessed the CD11B and CD18 expression on the neutrophils, which help in trafficking of neutrophils. There has been conflicting data in the past with with preclinical studies showing that giving Neulasta actually enhances these receptors, but the clinical studies haven't corroborated that, and even we couldn't corroborate that these upregulation of these is associated with outcomes. Even ADCC and CMC, when we tested it in vitro, did not correlate with outcomes. What we did find that oxidative burst, not the intensity, but the rapidity of oxidative burst, especially during the initial cycles, was associated with better outcomes, better CRs, better PFS and OS.
That's fantastic. One question. Was there any correlation between how high the white counts were in the responses?
So we haven't actually looked at it yet, but that's a really good suggestion, and I think we are going to do that for the paper.
Excellent. Very good. Congratulations, Pallavi.
Thank you so much. Thanks for having me.
Thank you. All the best.